In the history, together with that information, I want to ascertain the duration, onset, and progression of symptoms. I'll inquire about incontinence and enuresis, red flag symptoms such as visible hematuria, recurrent urinary tract infections, pain, focal neurology, and weight loss. I'll also ask about any family history of prostate cancer. And then I will inquire about his general health, comorbidities, regular medication, including anticoagulants, drug allergies and performance status. I'll ask about his fluid intake, his bowel habits, erectile function, and any specific goals, concerns, or expectations that he might have. I'll also inquire about previous trauma to the perineal area and any previous surgery that he's had.
Okay.
I will then examine him in the presence of a chaperone, examining the abdomen for a palpable bladder, palpable kidneys and surgical scars, and the external genitalia. And I will perform some basic investigations, including a digital rectal examination.
Okay, so he's 63. He's quite symptomatic and he needs to strain to empty the bladder every time. Otherwise, he's quite healthy. He's on a single drug, antihypertensive, no previous surgical history. Examination wise, he's well built, BMI of 28. Otherwise, abdomen, external genitalia examination were normal. Digital rectal examination showed 60 cc smooth feeling prostate. Okay, what will you do next?
Okay, so in the clinic, I'll arrange a urine dipstick testing and send that for MCNS if required. I will review his forms, as I mentioned before, and post-void residual and urine flow testing.
Okay, so what is IPSS scoring? What are all the components of it?
So IPSS is the International Prostate Symptom Score. It's a reliable, validated score for men with lower urinary tract symptoms. It comprises 4 storage questions about frequency, urgency, incomplete emptying, and nocturia, and 3 voiding questions about intermittent stream, straining, and hesitancy. It also has a quality of life score, which is scored out of 6, and the rest of the scores are out of 5. 0 to 7 is mild LUTS, 8 to 19 is moderate, and over 20 is severe.
Okay, any other forms or scoring systems useful in this patient?
So I would like to see a SHIM score as well, please, to assess his erectile function.
Okay, how will you score in this SHIM score?
So the SHIM score is out of 25. It's an abbreviated version of the IIEF and assesses for various components of erectile function.
Okay, his SHIM score is quite good. So which means his score is towards which number? 25 or 0?
It's towards the lower end. Sorry, a good SHIM score, so good erectile function, is a higher number. Good. 22 to 25.
Good, that's a difference with IPSS, so I wish you to be aware of. Okay, so his SHIM score is quite good. It's scoring 21, so he has no erectile dysfunction. And his IPSS score is quite significant. He scored 20 out of 35 with quality of life 5 out of 6. What's your next step?
Okay, so I'd want to see his uroflowmetry and post-void residual, please.
He had his uroflowmetry, which showed a maximum flow rate of 9 ml per second. It definitely showed a obstructive pattern, and he voided 500 ml with a residual of 230 ml.
Okay, so I would ask the patient if that's a representative void for him. Ideally, he should complete another 2 for comparison, but this demonstrates, as you mentioned, evidence of obstruction, a Qmax of men with a Qmax of less than 10 mils per second have a 90% chance of obstruction. And this, in combination with his digital rectal examination findings, point me towards benign prostatic enlargement. I would offer the patient some tamsulosin, 400 micrograms once a day, after discussing conservative measures. So conservative measures include adaptation of his fluid intake, particularly if there's a nocturia component to his symptoms. I would warn him about the side effects of tamsulosin, which are most notably postural hypotension and retrograde ejaculation. I explain that this just means that when he orgasms, he won't produce any ejaculate, it will drop back into the bladder, and that is not harmful unless he's concerned about his fertility, in which case we'd need to think about alternative measures.
Okay, what conservative measures you will explain to him?
So I'll talk about maintaining a generally healthy diet, so 30 minutes of exercise at least 3 times a week, and a diet full of fruit and vegetables, ensuring adequate bowel habits. I'll stress the importance of a good fluid intake, avoiding carbonated beverages, although mostly his symptoms were voiding rather than storage, but still useful information to give to the patient.
Okay, what are all the predictors of benign prostate hyperplasia progression?
So this is based on the Olmsted study from 1999, which was a longitudinal study performed in a group of men in Minnesota, and that suggested that a prostate over 30 cc, a PSA over 1.4, a Qmax of less than 12 mils per second, a post-void residual of greater than 50 mils, or an age of 70 to 79 are all predictors of future progression of disease.
Okay, so this patient, you're starting him on tamsulosin, you have advised him the side effects. When are you going to follow him up?
So given his poor flow, I would also offer finasteride and explain the risks and benefits of that as well, which are most notably related to libido and reduced sexual desire. I'd also explain there's an MHRA safety alert from 2018, which talked about the risk of depression and suicidal ideation associated with 5-alpha reductase inhibitors, and ensure that he was happy to take that. I would then see him again in around 6 months' time, because given finasteride takes a longer time to work, and I would repeat his flow test and post-void residual at that time.
Okay, so you're going to follow him up in 6 months' time?
Yes.
Okay. Any other medications or why you don't consider urodynamics for him?
So urodynamics should only be considered in specific indications. The upstream trial demonstrated that routine care was non-inferior to the addition of urodynamics. So the EAU guidelines suggest patients under 50 and over 80, patients that have had previous invasive intervention for low urinary tract symptoms, and if there are concerns about whether this is predominantly voiding or obstructing pattern.
Okay. And is there anything, again, age cutoff, like beyond certain age you will prefer to have urodynamics done?
Yeah, so patients under 50 and over 80.
Okay. So why you want to do urodynamics if the patient got bothersome symptoms but Qmax is more than 10?
So if a patient has predominantly voiding symptoms with evidence of obstruction, so a low Qmax or a post-void residual greater than 150, that would be an indication for urodynamics.
Okay. What is your thought about phytotherapy?
So it's not currently recommended by the EAU guidelines, and I would explain that to the patient that I practice an evidence-based approach, and so I would not recommend it.
Okay, so you're seeing this patient in 6 months' time. What are all the important parameters you will look for?
So I will reassess his IPSS and SHIM scores. I will assess for side effects of symptoms. The Javan meta-analysis demonstrated a 4 to 10% risk of adverse side effects with tamsulosin. And I will do a mental health screen as well, if he's on a 5-alpha reductase inhibitor. Again, I will repeat his uroflowmetry and post-void residual to ensure that his symptoms are not worsening. And I would generally ask about what his thoughts are, if he wants to pursue. The next step would be surgical management, if that's something he wants to pursue or not.
Okay, the time is over now. We will stop now. How do you think you did, Tara?
I feel like I dropped in a lot of evidence.
Yeah.
Whether that's a good thing or bad thing, I don't know. I don't know if that detracts from the scenario.
But that's a good thing because especially for benign prostate and prostate cancers, it is better to drop in as much of the evidences as possible. And now the EAU 2024 guidelines were released last week. Hopefully you may be getting some access through someone, but it's not that necessary for this exam. And maybe we will try to see you getting at least the handbook. Maybe you can go through some major changes. And two other guidelines I prefer you to quote during the presentation, apart from what you have done, is the GRIFT guidelines, especially for bladder outlet obstruction, published last year, August 2023. It has got some valid points, some GRIFT sentinel metrics, etc. But it's more to do with the surgical aspect, but nothing wrong in bringing GRIFT because that is like a talk of the town, especially in UK. And the other guideline which I wish you to bring in is the NICE LUTS in men guidelines 2015 update. Again, it may not add anything, but being in FRCS exam, nice to quote NICE 2015 update, and of course one of the EAU's up-to-date one. And any patient after examining just complete with a focused neurological examination. And not many examiners will go through that or make it very significant one, but it's nice to have a focused neurological examination because we know that patients with neurological symptoms may present with this kind of LUTS. But of course there are separate tables with neurourology where you may be taken more in detail in that. Then other thing is you can take this patient that you will be seeing the patient in a one-stop LUTS clinic. Again, that is the one which was nicely prepondered well by the GRIFT guidelines. And there are various flow charts on what is the first presentation, what will be the urology service, how are we going to safely discharge the patient, etc. So you can say a few things like, for example, if you have, you can say we have established a one-stop LUTS clinic. I run this clinic with the help of a benign nurse. We have the facilities for a complete array of investigations like ultrasound, flexible cystoscopy, or even truss volume measurement if there is a need. And but if you don't have this facility, again I will strongly advise that I'm aware of one-stop LUTS clinic with these facilities available, but in my hospital I will see him in a regular outpatient clinic and I'll arrange the investigations in a different appointment. Okay. So this will further
sorry, is it worth saying, because I know if you're proceeding down surgical management you want an estimation of prostate volume with truss. Is it worth saying that sort of at this stage that if he's got significant symptoms, so I'm aware that we might end up going down that route, I'd get a truss in the first instance to further guide management, or would you?
No, not necessary. Not necessary for medical management, definitely. For medical management point of view, our digital rectal examination is enough because all we need is to know whether the prostate is more than 30 or less than 30 so that we can plan for monotherapy with alpha blockers or a combination treatment with 5-alpha reductase inhibitors. Since I mentioned the prostate is 60 cc, you have appropriately made it into a combination treatment, which is more than enough. You don't need much more information into more specific size and also anatomical findings like is there an intravesical enlargement, and if so, what is the size of the enlargement, etc. That will be more into the surgical aspect. But you can say that I will see the patient in one-stop LUTS clinic with these facilities to start with. That makes a very nice preamble that you are aware of the latest GRIFT guidelines from last year about the availability of everything in one stop, because GRIFT guidelines clearly says that these patients, men with LUTS, should come in and have all the investigations in one stop and should go home with a final decision. The final decision could be medical management, nothing wrong in it. Ideally, these patients should be started on tamsulosin or finasteride in the community by the general practitioners itself, but in real life it is not happening. So still we are seeing patients without any medical management started by GP. So it's worth thinking in that way. Other than that, I'm quite happy with your other presenting symptoms, focusing on the red flag signs, medical history, and neurological disease. As I said, you can cover in the examination. You can ask about lifestyle habits, like about his caffeine intake, etc. You have appropriately mentioned about the sexual functions you have covered. One thing is, it's commonly the storage symptoms are called as FUN, frequency,
Yeah.
urgency, nocturia. You have included the incomplete emptying as a storage symptom, which is little bit challenging. You need to be a little bit careful on that. Not many people will agree with that, because even though the incomplete emptying could be due to like hypocontractile detrusor or over distended bladder, chronic urinary retention, it can cause storage symptoms like urgency, overflow, incontinence, everything. Commonly, the incomplete emptying is due to an outflow obstruction. So it's more to do with the voiding symptoms rather than the storage symptoms. So just be careful, unless if I am missing anything, I don't know. Incomplete emptying should be mostly kept under the voiding symptom, not in the storage symptom. And SHIM score, that's good. So I really want people to know that the SHIM score, it works exactly opposite to IPSS score. In IPSS, higher the score, patient is more symptomatic, while in SHIM score, higher the score, patient is normal. 25 out of 25 means normal. So as you know, it has 5 components. You can remember the components, like for example, a good libido and having interest to have sex. Then second one is something like a good amount of erection so that they can have a penetrative sex. Then third one is like a good penetrative sex long enough for satisfaction. Then fourth one is like a overall satisfaction and able to last longer. And fifth one is an appropriate ejaculation. And everything can be scored out of 5, and if everything is good, it's like 5 out of 5. So a patient with an absolutely normal sexual activity will have a score of 25 out of 25. So you can easily remember the SHIM score also. May not be for this scenario, but there will be a scenario where you may have be asked more about the SHIM score. And even though I asked you about the phytotherapy, it's not a bad habit to mention that I will not go for phytotherapy, but it depends upon how the time works. If the time is available, we can play it out like that. But otherwise, sometimes the examiner can ask you about phytotherapy, and you should be able to say that there is no role for phytotherapy as of now. There is not much evidence to support that. And even the Cochrane review and a few other publications also proven that phytotherapies were not useful. So you should be able to say that. And I'm glad you brought out the MHRA's advice on the possible suicidal tendency with 5-alpha reductase inhibitors. It is not that much well versed and well used in the clinical practice, but nothing wrong in saying that. You can say that you got a dedicated information leaflet. We got a Bowes information leaflet on male LUTS. You can use those male LUTS Bowes leaflets. So don't miss the leaflets whenever you are discussing anything. Other than that, NICE guidelines and GRIFT are the 2 main things I wish you to brought in the early stage itself. The one last thing is, since you're starting both tamsulosin and finasteride as a combination treatment, you can bring in some evidences to show that the combination treatments are quite good. Like for example, the MTOP study or combo dart study, you can bring in. Sometimes examiner may not ask you, but prostate cancer and benign prostate tables, if you bring in more evidences, the chances of touching that A mark 8 is quite high. You are almost there, but you can easily bring these 2 studies, which are quite standard and age-old studies. And other than that, I'm quite happy with everything. Regarding the follow-up, I will say, since you started tamsulosin also, to review in 3 months time. Ideally, as per the NICE guidelines, we should review in 4 to 6 weeks time for an alpha blocker. but logically it's quite difficult in NHS to have a review in such a short period. So you can say, I will review the patient in 3 months time. He will be suitable for a telephone clinic. Those things will make your answers look better, because there is no point in seeing him face to face. So you should bring telephone clinic, you should bring patient initiated follow-up in your discussions. Those are the new things. 2023, 2024, those are the new things. So I will bring the patient, and I will use PROM based another IPS scoring to see how he is behaving with the alpha blocker. Since you're starting alpha blocker, I will prefer you to say 3 months follow-up rather than 6 months follow-up.
Okay.
Yes, you are correct. Finasteride, it's 6 months, but since you're starting tamsulosin, we need to know how the tamsulosin is working. Okay?
Yeah, brilliant. Thank you.
Good. Well done.